is on endocrine issues. We have a very renowned person to talk to us on that, Dr. Vaman Khadilkar. He's a consultant pediatric and adolescent endocrinologist. He's got a lot of papers to his credit. He has a PhD from Pune University in the Department of Health Sciences, a past president of a lot of national organizations. And then here we have, he's going to talk to us on the endocrine problems that we see in persons with Down syndrome. So what is to be screened and how do you follow up and what treatment is to be given?
First of all, I would like to thank Dr. Rekha to invite me here to give this talk on endocrine or hormonal issues which are very specific to Down syndrome. Well, I think you must have seen this slide several times during this conference, that it was first described in 1862 by the English physician John Langdon Down, after whom this syndrome has been named. But it took nearly 100 years after that to actually map the chromosomal abnormality related to Down syndrome. And again, it was a French physician who discovered that there was trisomy 21. And interestingly, when you look through the literature, you find this beautiful painting where it has been suggested by this early Netherlandish painting, which is depicting a person with Down syndrome as one of the angels. And indeed, these children are absolute angels. They are just so lovable, so loving, and indeed, they are really incarnations of God. So we have to look at it in a very positive way, in a very holistic way. Now, endocrine system primarily is our own hormonal system, and as you can see in this slide, it consists of a very well orchestrated system which starts from brain, then pituitary gland, which governs all other endocrine system of our body. So pituitary is the master of the entire hormonal orchestra. So pituitary gland sends signals to the thyroid, adrenals, ovaries, testes, and many other systems in the body, which include parathyroid hormone, the bones that you just heard. The gentleman before me highlighted one very important aspect of osteoporosis in children, and I'll touch upon that quickly during my talk. But this is what consists of the endocrine system. And primarily, the meaning of the endocrine system or hormone is a chemical or a substance which is secreted at one place in the body but acts at another place. That's a hormone. So, insulin gets secreted in the pancreas and it acts on all the body cells which are away from pancreas. Similarly, thyroxine secreted by the thyroid gland doesn't act on thyroid, it acts elsewhere. So that's what a hormone is. So what are the common abnormalities that we tend to see in children with Down syndrome? What are the hormonal abnormalities? Now the commonest, as you heard our chairperson mentioning, was the thyroid problem. The commonest problems are thyroid, and in that too, hypothyroid. Hypothyroidism, although a single disorder, please remember it's of two varieties, congenital and acquired. So congenital is when you're born with hypothyroidism. And that's a much more severe condition as compared to the other one, the autoimmune or the acquired hypothyroidism. And in children with Down syndrome, congenital is rare, acquired is more common. The other problem is thyrotoxicosis, which is exactly reverse of what happens in hypothyroidism. So in hypo, the secretion of thyroid gland is less. In hyper, it's more. But hyperthyroidism or thyrotoxicosis, fortunately, is a rare condition even in Down syndrome. Then diabetes. See, remember there are two types of diabetes, type 1 and type 2. Type 1 is autoimmune insulin dependent diabetes, and type 2 is the insulin resistance diabetes. And both can occur in down, but type 1 diabetes is a little more common than type 2. Short stature, universal. Almost a universal problem in children with Down syndrome. And that's not really as a result of a hormonal disorder, but it comes under the umbrella of hormonal disease, so I have included it. Obesity, you heard. Obesity becomes much more common as they get older. And I'll come to that in a minute. Now, hypogonadism and puberty issues. For a very long time, people have recognized that children with Down syndrome may have issues in boys related to genital growth and in girls related to menses. And we will talk about that as we go along. And the last, but the one that is getting more and more important as longevity of these children is increasing is the low bone mineral density and repeated fractures as may happen as they get older. So coming back to the first issue, hypothyroidism. See, it's the commonest hormonal abnormality in children. It affects about 10 to 40% of all children with Down syndrome, and as their age increases, the percentage goes up. Every newborn, whether it is Down or not, must have a thyroid function test done. And especially when they have Down syndrome, we must check for hypothyroidism at birth, and then subsequently almost every 3 monthly in the first year. So if they are found normal at the neonatal thyroid screening, then you would do once in 3 months in the first year and every year after that throughout life to check for presence or development of hypothyroidism. Now, how do we treat this, or first of all, how do we diagnose it? See, there are often confusion amongst people's mind that doctors ask for T3, T4, TSH. They sometimes ask for free T3, free T4, and TSH. Primarily remember, T3 and T4 are the hormones which are secreted by the thyroid gland, and TSH is the hormone that controls the thyroid gland, secreted by the pituitary gland. So when doctors are asking for these three hormones, they are looking at both aspects. They are looking at whether the thyroid gland is functioning normally or not, and whether the pituitary gland is controlling it properly or not. But why do we then end up asking for free hormones? The reason is, free hormones are generally more accurate than total T3 and total T4 that you commonly get. So whenever there is doubt in the mind of a doctor about the diagnosis of thyroid condition, they would request you to do another test, which is usually free hormones. And in hypothyroidism, what do you get? You get low T3, low T4, and a high TSH. The reason is, as I told you at the beginning, pituitary is the master of all these glands. If thyroid is underfunctioning, pituitary will start shouting at thyroid. And how does it shout? It shouts by raising the TSH. So when the TSH is high, T3, T4 are low, your patient has hypothyroidism. Once detected, how do you treat it? Treatment is very simple. It's just a thyroid tablet taken every morning, fasting. What is most important to remember is that thyroid tablet must be taken on empty stomach. As soon as the child brushes his or her teeth, give the tablet with water and wait for half an hour. That gap of half an hour is critical. If you feed the child immediately, thyroxine is not going to be effective. So make sure that your patient takes the thyroid hormone on empty stomach and then waits for half an hour. Thereafter, you can feed. And as shown here in the slide, there isn't as yet a preparation that you can take once a weekly or once in 15 days. You must take thyroid tablet daily. There are some research molecules in the pipeline which in future we may be able to offer you on a weekly basis, but not at the moment. And once you have made a diagnosis, it is important to keep checking the thyroid hormone results every 3 monthly in the first 3 years, and then 6 monthly to yearly thereafter. And usually, the treatment is lifelong. Once hypothyroid is likely to be hypothyroid all life. Thyrotoxicosis, as I said, also known as Graves' disease, is exactly the opposite of what I said. So in this condition, your thyroid gland is hyperactive. It's producing too much of thyroxine. So as you can imagine, your T3, T4 are high and your TSH is low. So it's exactly reverse. How do you know the child is thyrotoxic? It causes weight loss, protrusion of the eyes, rapid heart rate, hyperactivity, irritability, lack of sleep, generally anger, and sometimes even diarrhea, weight loss, polyuria and polydipsia. That means drinking too much water and passing too much urine. That can also happen in thyrotoxicosis. Once you make a diagnosis, again the treatment is fairly straightforward. You can treat it with twice or thrice daily dosages of a medication called methimazole or carbimazole. Thyrotoxicosis requires more careful follow-up. So your doctor may ask you to do thyroid function test even 6 weekly or 2 monthly. It's a much more difficult condition to treat. And generally you would be requiring treatment for 4 years or more. Beyond that, some patient may completely be in remission and you can stop the medication. Now diabetes. I mentioned earlier there are 2 types. Type 1 is autoimmune, just like your hypothyroidism, which is an autoimmune disorder. Now a lot of you may not understand what an autoimmune disorder is, but to make it simple, see, our body has an amazing ability to recognize what is self and what is non-self. In the sense, if you take out a small piece of my skin and graft it on yours, it will die. The reason is your body will immediately recognize that this is not my skin, this is not my piece of tissue, and I'm going to reject it. So that ability to recognize as self and non-self is the key for survival. But at the same time, in some situations, it can be counterproductive. So what happens in autoimmunity is that your own tissues, your own thyroid gland, your own pancreas, may appear to your body as foreign. So although it is your own, your body feels this is not mine, I must kill it. So body then develops antibodies and over a period of many years kills it off. So these disorders are called as autoimmune disorders. And in Down syndrome, because they do have a slight problem with their immune system, they tend to get more autoimmune disorders. So just like your thyroid, your pancreatic islet cell get damaged over a period of time through this relentless process of autoimmune destruction. So they develop insulin-dependent diabetes, and when they get diabetes, they have to be treated with insulin. And again, the second variety is insulin resistance. That is, from 5 years onwards, every child who has Down syndrome is likely to become obese. They tend to get more and more fat. That's just an inherent property of Down syndrome. And when that happens, you develop insulin resistance. So you produce insulin, but it's not acting on your body. So again, you get high sugars and diabetes. That can be managed by oral medications, whereas type 1 has to be managed by injections. Now when a child with Down syndrome gets diabetes, it can only be managed by 3 or 4 insulin injections every day, and you have to monitor the sugars every single time. So that is a disorder that requires a lot of input from the entire family, the physician, the caretakers, and the whole thing rotates around the child's diabetes. So remember, if unfortunately diabetes happens, that's going to take a lot of more care. A lot more care is to be given for this. Fortunately, type 1 diabetes is not very common in Down syndrome. Then growth and short stature. As I said, short stature is almost universal in Down syndrome, and growth monitoring is essential. It is quite common that in the first few years, children with Down syndrome are almost on the 3rd or 5th percentile of the normal growth charts. But as time goes by, they start dropping on the growth percentiles. On an average, they are about 500 grams below the average birth weight for that community, and they're a bit shorter at birth as well. Also, during puberty, they don't get the same pubertal growth spurt as normal children do. So, taken together, they become short adults. Now, please remember, how do you monitor growth of children with Down syndrome? You should not be using the normal growth charts. You actually need to use these Down syndrome specific charts, which I have put up on the slide. So the pink charts are for girls and the blue are for boys. As yet, we do not have India-specific Down syndrome charts. But if you look at most of the studies published from India, the final height of our children is about 6 to 7 centimeters shorter in both sexes as compared to the Caucasian growth charts which are available. Now, why you must monitor using these charts is if your child is developing hypothyroidism or another growth-related problem, it can only be picked up on Down syndrome chart. It cannot be picked up on a routine growth chart. So, ask your physician, ask your doctor to provide Down syndrome specific growth charts, or they're easily downloadable from the CDC website, so you can use them. And if you do a DEXA scan on children with Down syndrome, they have much leaner body mass, lean body mass. In the sense, you heard the orthopedic surgeon before me speaking that they are hypotonic. Of course, they are very hypotonic and they have a low lean body mass. And proportionately, they have much more body fat. So taken together, they are much more adipose than a typical normal child. And because there is a high incidence of obesity in Down children, it is better not to use Down syndrome specific BMI chart to diagnose obesity, but to use normal children's BMI chart. So if you download the BMI chart from Down syndrome from CDC and keep plotting BMI of your Down syndrome child on it, you are less likely to diagnose obesity. You will diagnose it much later. So for the purpose of obesity, use BMI chart of normal children. Now, these are a couple of last slides in my presentation that the orthopedic surgeon just touched upon the low bone mineral density. Now, what is the cause of low BMD in Down syndrome? It's multifactorial. Obesity, low physical activity, low muscle tone, low calcium, low vitamin D, decreased muscle mass, decreased sun exposure, malabsorption syndrome, and often the anti-epileptic medications that these children are on together cause reduction in vitamin D level, calcium level, and low bone mineral density occurs. How do you diagnose it? The only known way to diagnose it is by doing a DEXA scan. DEXA scan remains the gold standard of diagnosing low bone mineral density in children. Under the age of 3 years, it's very difficult to diagnose, but beyond 3 years, yes, we have baseline data that can detect Down syndrome patients with low BMD. Now, as the children are living longer and longer, which is great, the problem of osteoporosis is becoming more and more severe and known because they are more likely then to have orthopedic disabilities and fractures. At the moment, this is an area of active research to find out whether drugs like bisphosphonates given at a younger age will prevent osteoporosis, but as yet we don't have any conclusive guidelines to treat children with Down syndrome with low BMD. Puberty and fertility. As I said, a lot of children with Down syndrome, especially the boys, do come to physician for micropenis or underdevelopment of genitalia. And its prevalence is about 10% in boys with Down syndrome. But when we check their hormones are normal. So it's just a physical feature that exists. Now, as shown in this slide, almost all children with Down syndrome will enter puberty at almost the normal time as rest of the population. And the progress in puberty is also pretty good. Some children may have problems with puberty and fertility, but many Down syndrome patients have fathered or mothered children. So remember that it is important to know that they will enter puberty at the right time, and the puberty has to be managed effectively in the children, which is not always easy. So there is thus a need to have an open discussion with the adolescent Down syndrome child who is entering puberty regarding changes that he or she is going to perceive, how to cope with them, sexuality, parenthood, and safety. So to conclude what I said, Down syndrome is the most common chromosomal abnormality, as you know. Bone health in this disorder is an area of active research and of growing importance, and as life expectancy of these children increase. The belief that these patients are infertile is untrue, and they experience puberty at a similar rate, and the tempo is normal. Autoimmune disorders, which we mentioned, hypothyroidism, thyrotoxicosis, type 1 diabetes, are more common in children with Down syndrome, and obesity remains a common problem, and so does short stature, and you do not treat these children with growth hormone. Please remember, there are a lot of people who could afford growth hormone to treat their Down syndrome child with growth hormone. But growth hormone primarily is a compound that makes the cell divide rapidly. And as many of you, I'm sure, are aware, that these children have a propensity towards development of hematological malignancies. And therefore, giving growth hormone is not safe. And I haven't treated a single child in my career who has Down syndrome with growth hormone. Some of my colleagues in UK have started doing it, but that's only under clinical trial situation. So at the moment, for short stature, we do not have an effective treatment. But if you pick up the hypothyroidism early and treat it effectively, I think they will at least reach their potential. Thank you.
Thank you, Dr. Khadilkar. You have made a very complex topic and very simple for the audience to understand. I think these topics are really a headache even to doctors, but then I must thank you for doing it in a very simple way.
Thank you, sir.
The topic is open for discussion. Before I just make a comment that, you're talking about hypothyroidism. I heard somebody say, God asked you that he wanted to give you an intellectually disabled child, what will you opt for? The answer is Down syndrome, because they are the best of the lot. And if you have a Down syndrome child and God said, I want to give you an endocrine problem, I think you should opt for hypothyroidism, the easiest to treat. So over to you for the questions.
My son has he has a thyroid problem. He's currently on Thyronorm. So last year or the year before that, his thyroid levels had come to like a normal level. And but the doctor said he still needed to continue the medicine. So is it like because you started it once, it's there forever, even though your levels are normal?
Your levels have become normal because you're giving thyroxine.
Okay.
So he is now thyroxine dependent.
Okay.
And if you withdraw the medication, the TSH will again go up and T3, T4 will drop. Because as I mentioned in my talk, the autoimmune damage is permanent.
Okay.
So once body starts killing the thyroid cells, it's a relentlessly progressive process. So your child will require thyroxine on a regular basis, even when you find that the levels are normal, because they're normal after having taken the tablet.
So you cannot reduce the dose or something, like from a 25 mg if he's to like a 50, but at 50 he's...
Your question is right, but the way a doctor would know that it's time to lower the dose is when the TSH gets suppressed.
Okay.
So body then tells us, the master of the endocrine orchestra tells us that you are taking too much.
Okay.
That's the time to lower it.
So
Beg your pardon?
does it lower?
Yes, as the TSH lowers, then only you can...
No, but does it happen? Does it really happen?
Yeah, it does happen in some children, especially when their growth comes to an end.
Yeah.
The demand over the thyroxine reduces.
Okay.
And in fact, most children, once they go through puberty, their dose comes down.
Okay.
But it usually doesn't disappear.
Okay. So once on Thyronorm, you are on Thyronorm for good.
I think so, in most of the situation, although there are exceptions. Yeah.
Okay. Thank you, doctor.
Sure.
My son was detected with this hypothyroidism in the year 2002. So he is on the Thyronorm medicine. And at that time, it was detected because he was not interested in doing anything. He was lazy and he was not talking and all. And then this medicine started, so his levels were okay. But still, in so many years, he's still very, he's still not doing anything, doesn't want to do anything. So he's still, and then they started depression medicine because they said he's depressed. So the two symptoms probably are similar, so we don't know. And after giving this medicine for depression and this, he got epilepsy now.
Oh, that's
So
very
I
sad
don't know
actually.
now what is
Yeah.
this due to the medicines or is it happen naturally? We are very confused because one doctor says this is not my domain. He's depressed, you take him to a psychiatrist. I take him to a psychiatrist, he says, then he got this epilepsy. So I went to this neurologist. He says that his behavior is not my domain. So you go to a psychiatrist, so we are very confused with this
I
whole
think you're right.
situation.
To an extent, super specialists have become modular rather than holistic. So we kind of, as super specialist doctors, tend to describe elephant in different forms, like the standard story. But yeah, you need to have a holistic approach. And I think in your son's particular case, I feel it's a combination of multiple things. So it's hypothyroidism, there may be an element of depression, and the anti-epileptic medication themselves will make him feel very lethargic. So I think, yeah, so you are in a situation where things are not easy at all. And not very many doctors would be able to tell you clearly as to this is the cause. I think it's a combined effect of everything.
Same body and different people are seen from different angles. So if there was something, if they can always, say there's something common because they say that's not my domain. So we are very, we are confused. We don't know where to be sitting in a psychiatrist.
Yeah.
He's a very good answer to Shama, but now he was working also.
Right. Can you please use the mic, then I can hear you actually.
Good afternoon, sir. My daughter is 8 years old. She is hypothyroid, and we did this ultrasound of her glands, and we found some cyst there. So now we are not sure whether that is due to the cyst or is due to the trisomy 21. Now the point is that doctor has advised me to go for a cobalt test. But I'm afraid of using radioactive element on a 8 years old child.
Yeah. See, you don't have to go for radioactive iodine scan. You can just use something called technetium-99 scan, which is not a radioactive material, and that will tell us whether that thing, the round cystic thing which is seen on ultrasound, whether that is producing any hormone or not. Or in medical language, it tells us whether it's a cold or a hot nodule. If it's a hot nodule, then it's a different story. Cold nodule, different story. So my suggestion is, I entirely agree with you. An 8-year-old doesn't really require to go for a radioactive scan. You can just use something called technetium-99 scan, which is not a radioactive material. TC-99 scan.
Thank you, sir.
Sure.
I think we'll have the last question.
Hi, doctor. I have a 2-year-old daughter, so she has hypothyroidism. So she is on medication, Thyronorm, 12.5 mcg. So her initial was like 12.75 TSH, and then it came down to 1. And now it's going up again, like it's 3.75 right now. But she is on continuous medications.
Yeah.
One of the friends, like D3 and TSH are like interlinked. And if you have D3 low, then you will have TSH high, which may be there. So her D3 was 30 at that point of time, then it went above 90. So right now it is 95, 96, which is like the optimum level which can be maintained. So my question is like, for particular case of Downs, is it like there is an optimum level which is not actually the range which is defined generally in the many of the tests? Because they are not conclusive for Downs. Like they give range between 3 to 5, but it is considered like for Downs it should be nearly 1 or below 1. That is considered like the optimum.
I think this is a situation where I would use a free hormone, as I mentioned. I would do free T4, free T3, and would try to keep the free T4 in the upper normal range and TSH below 2.5. That is the simple way of looking at it. TSH below 2.5 and T4 in the upper normal range. Upper normal T4 is most critically important because that's the metabolically active hormone and is going to be utilized by the brain. So,
Thank you.
Thank you very much. I think if you have any more questions, we're already running short of time, 15 minutes. I think Dr. Suresh wants to leave, please. He wants to leave after the next session.
Okay.
So that's why. You can talk to him after that. So Dr. Khadilkar, thank you very much.